Hi there, my name is Ling, and I'm one of the foundation doctors working in Nottingham University Hospitals, and it is my pleasure and privilege this week to present to you this week's online learning on how to approach jaundice as a presenting complaint. So, jaundice is simply defined as the yellowing of the skin and sclera as a result of the body's inability to process bilirubin properly. There are probably 100 causes to jaundice, and it is not an easy, common presenting complaint to tackle. But with a few key basic principles under your belt, you should be able to approach jaundice confidently and tell different groups of causes apart from each other. So, the aim of our presentation today is to help you to learn the few key basic principles that underlie a proper approach to jaundice as a presenting complaint. First, it would be good to have a mental list in your head of the common and possible differential diagnoses that could commonly contribute to jaundice. We can use the anatomical or surgical filter. Using the anatomical filter, the causes of jaundice are classier as to where the pathology originates anatomically. So the pathology can lie in the vascular system, in your liver, in your gallbladder, in your bile duct, or in your pancreas. Please feel free to pause this video to peruse further. Next, using the surgical filter, we decided to use the mnemonic vitamin C, D. So we class the pathologies based on their offending categories. Once again, please feel free to pause the video. Please also note that this is not an exhaustive list, but rather a list of common differentials that could lead to jaundice. So the first step to our approach is to determine the pattern of injury. So you should distinguish whether the jaundice is pre-hepatic, hepatic, or post-hepatic. That would be your first step. And these can be determined by urine color, stool color, and a basic set of liver function tests. Next, this table concisely summarizes the main key features distinguishing pre-hepatic, hepatic, and post-hepatic jaundice from each other. So identifying the correct category of jaundice early on in your assessment will be vital to investigating the various differential diagnoses that lies in each category. So once again, please feel free to pause this video and have a look at this chart. Now, let's have a head start. So once again, the first step to determine which category the jaundice belongs to is to distinguish the urine color. What is the urine color? A normal urine will tell you this is prehepatic jaundice, which is from raised unconjugated bilirubin. So remember, only conjugated bilirubin is water soluble and can be excreted in the urine. As for dark urine, there are more questions to follow. So, if your patient has dark urine, the next question to ask is what is the color of the stools? Pale stools will tell you this is a post-hepatic obstructive jaundice. And if you have normal stools, a simple blood test will further narrow down and nail the class of the jaundice. And this simple blood test is your liver function test. Next, ask yourself what is the pattern of the LFTs. So a normal LFT will tell you that the jaundice is pre-hepatic. An LFT that has predominantly raised transaminases, raised AST and ALT, will tell you this is a hepatic origin. And an LFT that has predominantly raised ALP will show that this is a cholestatic pattern showing that the jaundice is obstructive and post-hepatic. Now, the second step, once you've identified the category of the jaundice, is to look for differentials within the category. So here we shall look into each category individually and branch out our concept map from here. So let's have a head start. Now, let's have a further look and scrutinize the potential and common causes of post-hepatic jaundice. When it comes to post-hepatic jaundice, the first question you need to ask is whether this is painful or painless jaundice. So the key principles here are: painful jaundice is almost always due to gallstone disease, and painless jaundice would suggest pancreatic malignancy or biliary structures. And these two key principles apply once you've identified that this jaundice is post-hepatic. And once again, do consider Courvoisier's law. In a patient with painless jaundice and an enlarged gallbladder, the cause is unlikely to be gallstones, and it therefore presumes the cause to be an obstructing pancreatic or biliary neoplasm until proven otherwise. Now, in painful jaundice, firstly you need to look out for Charcot's triad, which is fever, pain, and jaundice. And if this triad is present, you should suspect cholangitis. Remember, cholangitis is a medical emergency because these patients can deteriorate rapidly. They need blood cultures and empirical antibiotics urgently. In patients with positive Murphy sign, it is almost always due to cholecystitis. That's because the pain from Murphy's sign is due to the inflamed gallbladder catching under the examiner's fingers during deep inspiration. Other common potential causes would include cholelithiasis and hepatic abscess. These causes can be differentiated on HPB imaging, initially through ultrasound and CT abdomen. Now, in painless jaundice, ask yourself, what are the associated features? Now, learn to detect clinical pictures or clinical patterns. In painless jaundice with pruritus, and especially in middle-aged females, you should suspect primary biliary cirrhosis. Test for anti-mitochondrial antibodies as they will be positive. They're very sensitive. And in painless jaundice with weight loss, suspect cancer. Common possible causes would include periampullary masses such as pancreatic cancer and cholangiocarcinoma. In painless jaundice with inflammatory bowel disease, suspect primary sclerosing cholangitis, as these two tend to come together. Now, let's explore the hepatic causes of jaundice. This is actually a huge topic alone to digest and requires understanding of the many categories of liver injury. So listed here below are the broad categories of liver injury that we will explore next and identify the potential causes and differentials in each category. Having an understanding or a mental understanding of these categories will be helpful for you to identify the many causes of liver injury. So once hepatic jaundice is identified, it is essential to do a full liver screen in the patient to ascertain the cause of the liver injury. It is impossible to nail down the cause of the liver injury through signs and symptoms alone. However, there are questions in our history that we can ask to increase our clinical index of suspicion for certain categories. Firstly, for lifestyle-related liver injuries, you should ask for history of chronic alcohol abuse, as this could allude to alcoholic liver disease. A patient presenting with diabetes, hyperlipidemia, obesity could allude you to non-alcoholic fatty liver disease, both of which can progress to cirrhosis if this is left undiagnosed. Now, be aware of medications that could lead to liver injury, most commonly paracetamol overdose that could lead to fulminant liver failure. Think about your anti-TB drugs. They are notorious for their hepatotoxicity as well as anti-epileptics. A full medication review of your patient would be essential to look for these causes. Viral hepatitis is also an equally important cause. In your history, ask for unprotected sexual intercourse, IV drug use, recent travel, and any history of contaminated food intake. Exposure to uncooked shellfish could lead to hepatitis A, and remember, Hep B and Hep C is blood-borne, and Hep A and Hep E is through bodily fluids. As for metabolic causes, young patients with neuropsychiatric features and evidence of liver injury should raise your suspicion for Wilson's disease. In a patient with golden bronze skin, early onset diabetes, and endocrine features with a positive family history of early onset liver disease should raise your suspicion for hemochromatosis. These are the two metabolic liver causes to be aware about at your stage, and some liver injuries can be secondary to right-sided heart failure, which will present with hepatomegaly, peripheral edema, and right upper quadrant pain. Also be aware of Budd-Chiari syndrome, which is your hepatic vein thrombosis, and they will present with similar features as well due to congestion of the liver. Autoimmune causes should also be excluded, and diagnoses can be made with the presence of autoantibodies, and this will form part of your full liver screen, so you won't miss that. And if you have a young patient presenting with COPD who's also a non-smoker and has liver failure, you should suspect alpha-1 antitrypsin deficiency. As for prehepatic jaundice, the main key principles underlying this type of jaundice to ask yourself would be, is this hemolysis or is this reduced hepatic uptake? And serum lactate dehydrogenase, haptoglobin, and reticulocyte count will be able to reveal whether there's underlying hemolysis. Potential causes of hemolysis would include G6PD deficiency, thalassemia, recent incompatible blood transfusions. Please note, the examples I listed is not an exhaustive cause for hemolysis, it's rather just a bird's eye view of hemolysis leading to presentation of jaundice. Be aware that some drugs can lead to reduced hepatic uptake of unconjugated bilirubin, such as rifampicin and probenecid. And in Gilbert's syndrome, this is a genetic defect leading to reduced hepatic conjugation of bilirubin, and it is small marked or severe in times of stress. So a presumptive diagnosis can be made in an asymptomatic patient with mildly elevated bilirubin and an otherwise normal liver function test, once causes of hemolysis and medications are excluded. So thank you for bearing with me until this point. I would like to end with a few key points. So jaundice is classified as prehepatic, hepatic, and post-hepatic based on whether the bilirubin is conjugated or not and the pattern of the liver function test. Your urine and stool color will be very helpful in identifying initially what category this belongs to before the results of your LFTs come out. And once you've identified the categories of the jaundice, remember that in pre-hepatic jaundice, look for hemolysis and causes of reduced hepatic uptake of bilirubin. In hepatic jaundice, once it is identified, a full liver screen is essential to search for a cause of liver injury, and your history taking will be vital to assess for chronic alcohol abuse, drugs, recent travel exposure to contaminated foods, IV drug use, and unprotected sexual intercourse and tattoos. And remember, painful obstructive jaundice is almost always due to gallstones, in post-hepatic jaundice, of course, and in post-hepatic jaundice, painless jaundice is often due to malignancy, strictures, or primary biliary cirrhosis. So, my last few lines, remember, create your own concept maps. This is just a guide to help you to create your own concept maps and your own thought processes. Start thinking about your thoughts, double check to identify and rule out life-threatening causes. And remember to pause these videos at different stages of the concept map to see it in detail or to peruse it further. Thank you very much.